everyone, my name is Melanie Grant, and this is CNM Glass. This video is for the purpose of reviewing ICD-10 CM coding, factors influencing health status, or Z codes, in the Chapter 21 of the ICD-10 CM coding manual, guidelines for sections 1.C21 and all of the parts of it, and just some basic information on how to identify a Z code and where to find them. Our key points today, we're going to be talking about routine and preventative care, genetic susceptibilities, status, aftercare and observations, follow-up, donors, and counseling. And we'll be doing a part 2 video which goes over moms, babies, and some of the additional preventative and routine care for obstetrics and GYN services. So before I get started, I wanted to let everybody know this video is being recorded using the 2019 ICD-10 CM Expert Edition from the AAPC publisher, and I'll also be referencing the 2019 edition of the textbook Let's Code It by McGraw-Hill Connect. So let's go ahead and start by looking at first how ICD-10 classifies factors influencing health status. So the first thing to be aware of, and you may notice by looking at all of the information I put on the board, is that Z codes are generally used for conditions where the patient is not being seen or treated for an actual problem. Or they may have a problem, but they're not being seen for that problem, but rather the aftermath or some of the after services in relation to it. So these are all of your factors that they're coming in to get seen that have nothing to do with the actual sign, symptom, condition, or diagnosis. Okay, one of the first things I like to do when I start looking at Z codes is I like to go into the guidelines. As a new coder, this was really beneficial for me because I would always forget exactly, oh, where do I find the encounter for, I know the patient's being seen for a well woman check or a routine exam, but I can't remember what that term is. So while the term for any time they're getting seen for an administrative type or routine type of exam is encounter 4, oftentimes with the Z codes, it can be hard to remember all the different breakdowns. And so if you look in your guidelines, starting at section 1.C.21, and in my coding book, it's on page 26, you'll find that it breaks down all the different types of Z codes over several pages, going all the way through 29. So there's a lot of Z codes, and that's a good thing because there's a lot of reasons that patients are seen that aren't necessarily for a problem. The first thing that we want to look at is just some of our routine or preventative care. One of the things you want to keep in mind is what is the purpose of your visit? This is really identified in reading the notes, reading the chief complaint, the HPI, why the patient is seen, what they said to the provider, and also reading the actual plan and treatment options. Oftentimes, a patient can come in with the purpose of doing a routine visit, and they have something wrong with them. And so the doctor either does both the routine visit and a regular office visit to address those concerns, or they may say, you know what, I'm really concerned about this extremely elevated blood pressure. Let's focus on that instead. And so a lot of times what's scheduled for the visit may change. For this reason, it's important to read through the entire note to determine if was the purpose a routine visit or did that change, or did they come in thinking they were here for a condition that they didn't have, what was the final diagnosis, and going from there. Oftentimes, as new coders, we tend to get overwhelmed looking at the op note or the office visit note, and it can be a little confusing as to where to look. Now, I've provided some previous videos on how to read a SOAP note, and if you have any questions about that, feel free to contact me and I can provide links to that as well. But for this video, I want to talk about where we would go to find that purpose. So when you're looking at that purpose, it's typically in either your assessment or plan, but it's overall understanding of the video, of the note. So an overall understanding of the note, why the patient was seen and what was done about why they came in. So interpreting is key in that factor. Once you have that information though, and you've abstracted exactly what the purpose is, we come now to our Z code section to say, okay, the purpose is not to treat a condition, it's not a sign or symptom, and it's certainly not a diagnosis. If it's a routine or preventative care service, which can be called a lot of different names, we want to remember that that's an encounter for physical, an encounter for an administrative paperwork that they had to have filled out. Pay close attention to that because you're going to find the information that you need in the note. But also, feel free to come over and look at the Z codes and the guidelines of what's exactly available. Now you'll find information on encounter 4 under some of your routine administrative exams, as well as some of the other things, because you have other types of encounters. You have counseling, for example. If a patient's coming in for counseling based off of a concern that they don't necessarily have, such as a genetic factors, could I maybe have the genetic gene for breast cancer? My aunt passed away from breast cancer, and I would like to make sure that I speak to a genetic counselor to see if it's something that I might be concerned with. Do I have signs and symptoms? No. Do I have any other reason to come in aside from a family history? No. So the purpose of the visit would be encounter for counseling, or just simply, in this one, I think it has encounter for genetic counseling. Okay? And so you'll find all of these different kinds of things within the guidelines and when you look in your alphabetical. You can also go directly to the Z codes in your ICD-10 tabular section, although again, there's a lot of information in here. And so my goal for students is to show you the right way and also show you some of the other ways you can find coding, because everybody's going to find a way that works best for them. The most important thing is that you always, always, always verify your codes and always look in your tabular. Be wary of using unspecified codes or codes that use the term other unless it's directly referenced from the alphabetical to that section in the tabular, or unless you've looked at absolutely everything and are sure there's nowhere else that can be found. So that being said, I find my Z codes in my code book starting on page 1259. And it does repeat some of the specific guidelines that are indicated from the guidelines section. Always look at your categories before you move on to any coding selection. Look at the categories for that section and see if there's any specific section guidelines that apply, because that's going to apply to all your Z codes from Z00 to Z99 and in your other coding sections. Here I have a couple of guidelines. It says Z codes represent reasons for encounters. A corresponding procedure code must accompany a Z code if a procedure is performed. Categories Z00 through Z99 are provided for occasions when circumstances other than disease, injury, or external cause classifiable to categories A00 through Y89 are recorded as diagnoses or problems. Okay, so in other words, only use these codes if the purpose of the visit is, or the purpose of the service is not for something that can have an actual diagnosis assigned. This can happen when either a person is, who may or may not be sick, encounters the health services for a specific purpose, such as to receive limited care or service for current condition, to donate an organ or tissue, receive prophylactic vaccines or immunizations, or to discuss problems which is in itself not a disease or injury. Excuse me. So like we said with concern for breast cancer. Or they may come to the Z code section when a circumstance or problem is present which influences the person's health status, but is not in itself a current illness or injury. So those are things like history conditions or status conditions that the patient may have. So looking at that and just kind of having a good idea, on page 1259 you also have a table of contents, if you will, that identifies the different blocks of sections of Z codes. And so you have encountering health services for exams, genetic carriers and genetic susceptibility to disease. So if I did get a test that said, yes, I have the breast cancer gene, I would now be a genetic carrier because it would be known. Resistance to antimicrobial drugs. Let's see if I can speak today. So this would be something that's important to know about the patient, but not the purpose of the visit. Estrogen receptor status. Retained foreign body fragments. If a patient has something that from a previous injury that stayed with them and they're no longer injured, but they happen to have that body. So everybody knows of that one uncle that has a bullet still stuck in his arm for when he had a BB gun, something like that. Hormone sensitivity, malignancy status, and so on. So I'm going to let you read through all of those so that I don't mess them up too horribly. But you can see that we have a couple of different categories, including things like blood typing or BMIs, just regular daily information about your patient that we tell within the note that may affect the care and services provided. Now, one of the things to keep in mind when you're going into the Z codes is that it has to be relevant. If it's not relevant to the visit itself, it's not necessarily something we need a code. There are some codes such as HIV or pregnancy that we're always going to code when they're encountering services, because even though it may not affect today's visit, it's always relevant to be aware of. But I know that I'm a type A positive, but my doctors don't necessarily need to list that every time they see me, especially if it's a routine cold or a general physical. However, if I get surgery, that might be something important the surgeon should be aware of. So keep in mind, when is it relevant and when should we be listing codes? Okay, so the next thing to look at is screenings. Now, this is one of the areas I used to work in one of the local hospitals, and we would get lab testing all the time. And one of the most common issues I saw was with screenings and identifying what the purpose of a lab test was. So, again, we're going to come back to this purpose here. What is the purpose of the testing that we're sending out? If it does not have a known diagnosis prior to being sent, and they've stated the reason, we can oftentimes find a screening for conditions, such as screening for cardiovascular conditions when we're looking at lipids to see if there's any kind of cardiovascular disease. A provider may send a panel of lab testing for a lipid panel, and the appropriate diagnosis code typically to list for that if the patient does not have any conditions, does not have any signs or symptoms saying that there's a concern to look at lipids, and does not have any kind of histories that identify a concern. Then it falls under the term screening. It's very important that we talk to our providers and get them to identify the purpose of their screenings or have some sort of code set up with the office who's doing the billing, who's the coder, and really have good communication so that we know which ones of those are important and which ones should be listed for what reasons. Especially if you're working with Medicare patients, there's a lot of screenings that are covered for routine services or preventative services, but oftentimes they get denied. One of the biggest reasons they can get denied is that providers will identify a screening as part of the routine exam, but the provider's not performing the actual lab test. They're sending out for it, and so the patient's no longer out in the routine exam. Now, there is a code for lab testing for routine purposes. Some insurances take it, others don't. And it's all about what is documented as the purpose of your visit and what your provider's intent for those screenings are. Let's see. Beyond screenings, we also have two different types of history. You have family history and you have personal history. And just as it sounds, one's talking about the history of the family related from blood to the patient. Keep in mind, blood relations is important here because I may have an uncle that's married to my aunt who has diabetes, but that doesn't mean that it runs in my blood because we don't have any blood relation. So when we talk about family and it's relevant to the patient's care during that visit, we're going to list any kind of family history as it's pertinent. Same thing with personal history. I may have had a history of UTIs when I was 16 and I'm getting seen for a blood pressure check. If the provider doesn't link that there's some sort of connection there, we don't need to list a personal history of your urology conditions. We only need to list what's relevant to the visit. So if I had a history of UTIs and I was getting seen for a recurrent UTI, then that might be something that was relevant to list because it's related to the condition that's being seen for today. Also, if the provider says that it's relevant, even if we as coders don't necessarily agree, you want to keep in mind that it's the provider's assessment and purpose is to diagnose the patient. So if he or she says that that is relevant and should be listed, we always want to pick those up. Outside of history codes, we have some really confusing ones. A lot of times coders get confused between the differences between follow-up, status, aftercare, observation of a patient. So I have a couple of notes here I wanted to share on that. The first one I have is talking about status. Personal histories versus status can sometimes be confusing because a status is something that is no longer a problem that's being treated necessarily. When a current condition with a history of a same condition is repeated, oh, I'm reading the wrong thing. My mistake. Okay, so for status, is the purpose of the visit is to check on the status or condition of a previous condition where the purpose is not to treat a condition and the condition is no longer diagnosed. So one of the examples here is a post-procedural status. Once a patient has, so let's say a patient is seen for a cyst on their lungs. Okay, my son was actually seen for this, so this is something I can relate to. He went into the surgeon and had one of his lobes removed in a lobectomy. Every time he was seen after that, he no longer had a cyst on his lungs because that lobe was removed. And so the condition for the diagnosis that he had with the cyst on his lungs could no longer apply. He could list it as a history of, but the purpose of the visit was to check on the status of that, of how he was doing post-surgically. And so your status codes are going to be identifying something like where are you at in this condition. Now, this can be confusing because we have a lot of patients who have a post-surgical service but are looking at aftercare or follow-up. Okay, and so these two can be very confusing in how do I select which one. So status is no longer a diagnosis or condition versus aftercare. So aftercare applies for diseases where an additional care is needed. So let's say such as a patient who had a cardiovascular condition where they needed to have a pulse generator implanted, and that being a device may need routine maintenance. Aftercare would apply to any kind of changing of the device itself. They still have a heart, they still have a bad pacemaker, so they still need that pulse generator in order to keep their heart going, which means they still have the diagnosis or condition that originally had the surgery, but the care is related to the diagnosis, but not for the diagnosis. That's the best way that I can put it. Generally with something like this, the services are to a device. And so you'll see a lot of examples in your guidelines, and we'll look at a couple of those here in just a moment. Now our follow-up here is intended for a condition that is either treated and resolved and determined that we're just checking on them today. These are not things such as status of a surgery, but rather like, say, a patient who's here for follow-up after a resolved UTI. So oftentimes, a follow-up visit is is scheduled before the patient is seen to identify that the condition is resolved. And so they may have come in for that UTI, they took the medication they were given, and they came back. And some guidelines will say in that particular example you would code the condition. But if the provider wanted them to return an additional time as an additional follow-up once it's resolved, then it would code to a follow-up. So it's important to identify, did we know that this condition was resolved for the purpose of this visit? Or are we just checking to make sure it hasn't come back? And so that's going to be your difference, and it can be very confusing in comparison to status, but you want to remember that status is no longer a diagnosis or condition and has very specifics. Whereas a follow-up is more directed at the purpose of the visit, just to see if anything else has occurred. So that's it for some of these. I'm going to go ahead and pause the video and come back on a secondary video for today's lecture, where we're going to talk about some of these codes specifically with scenarios, and we can code them out. Stay tuned.